Mental illnesses are medical conditions that affect a person's thinking, feeling, mood, ability to relate to others, and daily functioning. They are treatable disorders. Individuals that suffer with mental illness can experience relief from symptoms with treatment, the support of loved ones, and help from mental health clinicians. There is a continuum for mental health and mental illness, just as there is for health in general. A characteristic of mental health, increasingly being promoted and essential to the recovery process, is resilience. Resilience is closely associated with the process of adapting and helps people facing tragedies, loss, trauma, and severe stress. Examples of disasters such as the attack on the World Trade Centers in 2001 and the devastation of Hurricane Katrina in 2005, in which people pulled together to help one another and carried on despite horrendous loss, illustrate resilience. Being resilient does not mean being unaffected by stressors. It just means that rather than falling victim to negative emotions, these people can recognize their feelings, readily deal with them, and learn from the experience. They can even help others with their own feelings if possible. People commonly make a distinction between mental illnesses and physical illnesses. It is an odd distinction considering that mental refers to the brain, the most complex and sophisticated part of the body, the organ responsible for the higher thought processes that set us apart from other creatures. Surely the workings of the brain, the synaptic connections, the areas of functioning, the spinal innervations and connections are physical. One problem with this distinction is that it implies that psychiatric disorders are all in the head, and therefore under personal control and indistinguishable from a choice to indulge in bad behavior. Although some physical disorders, such as a broken arm from skiing or lung cancer from smoking, are blamed on the victim, the majority of physical illnesses are considered to be beyond personal responsibility. Perhaps the origin of this distinction between mental and physical illnesses lies in the religious and philosophical traditions of explaining the unexplainable by assigning a mystical or spiritual origin to cognitive processes and emotional activities. Despite many advances in understanding, mental illness continued to be viewed differently from illnesses that originate in other parts of the body. Consider that people with epilepsy were once thought to be possessed by demons, under the attack of gods, or cursed. They were subjected to horrible cures and treatments. Today, most people would say that epilepsy is a disorder of the mind and not under personal control, because we can see epilepsy on brain scans as areas of overactivity and excitability. But there are no specific biological tests to diagnose most psychiatric disorders, no cranium culture for depression, and no MRI for obsessive-compulsive disorder. However, researchers are convinced that the root of most mental disorders lies in intercellular abnormalities, and we can now see clear signs of altered brain function in several mental disorders, including schizophrenia, OCD, stress disorders, or depression. The primary objective of the DSM-5 is to provide clinicians, researchers, psychiatric drug regulation agencies, health insurance companies, and pharmacological companies, along with policymakers, with a common language and standard criteria for the classification of mental disorders. It is important to stress that a DSM diagnosis classifies a disorder that a person has and not the person themselves. For this reason, the text of the DSM avoids the use of expressions such as a schizophrenic or an alcoholic. Instead, they use more accurate expressions such as an individual with schizophrenia or an individual with alcohol dependence. The DSM-5 no longer utilizes axes that were categorized 1 through 4, but now they are more in alignment with the ICD codes of medical diagnosis. Different cultures approach the same situations, diseases, or disorders differently. If that is misunderstood or misdiagnosed, it can lead to stigmatizing and mistrust. Stigmatizing attitudes toward the mentally ill can lead to negative feelings toward oneself and the motivation to seek treatment. One question to ask yourself is this considered bullying by the healthcare profession? We judge those with mental illness, but could possibly be discrediting a person unnecessarily. Healthcare providers must consider cultural norms when providing care for those with mental illness. History shows that clinicians interpret mental health according to one's own culture. Cultures differ in the way that they view mental illness and what behaviors are classified as bizarre. Some cultures induce an altered state of consciousness to reach a level of spirituality. One example is meditation or prayer. And these methods can be very calm or very active, depending on the religion.
The tricks, the flips, the jumps. He's unbelievable. He's focused, he's concentrating, he's just all wrapped up into this. He's fantastic and phenomenal.
I hold a part-time job as a substitute teacher at my local area schools, so I'm pretty comfortable as far as my day-to-day routine. I get up in the morning, I do some chores around the house, and then sometimes I will go to school and sub, and sometimes I will just stay at home and clean the house.
To me, love is the best thing any family can give any senior. If he wants to go around the kitchen, well, come around, do something, peel the potato, do the rice, check on the beans, little things like that, that would make them feel good.
My African dance teacher taught us a dance step, which is involved running, suspended legs high in the air between touchdown steps, but staying in place. My poetry is like, it's my truth. And if I'm not true with it, then I can't write it.
My name is Shravani. My son Arjun has been suffering with mental illness for the past 9 years.
Hi, my name is Grace, and I've had schizoaffective disorder for the past 12 years.
My name is Martha. My mom has been suffering with bipolar disorder for the past 42 years.
My name is Jacquees, and I've been diagnosed with schizoaffective disorder, and I've been dealing with it for 25 years.
One in every 5 families are affected by mental illness, and that is pretty much throughout the United States.
People think that there are specific types of people who can get this. Mental illness can hit anyone at any time. It doesn't matter how much money you have. It doesn't matter where you live. It doesn't matter what your occupation is.
It does not choose race. It does not discriminate.
I was at University of Tennessee in Knoxville. I was a 3rd year chemical engineering student. I had problems with hearing voices, suicidal ideations, irrational thinking. I had the total psychotic break when I was 20, and I couldn't do any of my engineering courses anymore. I couldn't form the equations, I couldn't comprehend. It took me 4 years to finish my last year of college because I was in and out of the hospital.
It was my junior year in college, and I was going for a pre-med specialty. I was planning to go become a doctor after school. I realized that a lot of my peers were having less trouble with the coursework than I was, and I didn't know why. Sometimes I would be studying for 6 hours and they would only need 2. My boyfriend took me to a psychiatrist and psychologist, and they confirmed that I had schizoaffective disorder. My first reaction was, no, that's not me. I don't have schizophrenia. And the doctor, the psychiatrist said, oh, yes, you do. You have the classic symptoms of it. My mother was not very positive about my having a mental illness. As a matter of fact, she threw me out of the house. Suddenly, it seemed like my life had taken a whole new meaning. I knew that I could not work, and I knew that I had to get better first. I was a caring, good person, and I was going to recover.
Que le arrebate el dinero, a mí se lo marchante, pero que tire ese plante también roba.
My mom was first diagnosed with depression when we saw that she was constantly in bed. And at that time, we knew that something was wrong, but of course didn't know exactly what. It wasn't Mom anymore. She had completely changed. We had to change our way of helping her. We didn't want to hospitalize her. We wanted to keep her home. Back in 2003, she had a crisis where she became catatonic. She really didn't know what she was doing. We couldn't help her anymore, so we had to accept the fact that she needed to go into a hospital.
Well, Arjun was always a social kid. He had friends that were unbelievable. Academically, he was all-around kid. His test scores for the national test scores used to be in the 99th percentile. Always loved and liked by everybody. When the illness struck he was fifth grade, everything just crashed.
My teachers would probably, they pretty much like singled me out from the rest of the class because they didn't know, like, no one really knew that it was a mental illness. They just thought that, like, oh, he's going nuts, so we might want to keep him away from everyone so, like, he doesn't, like, go crazy and flip out on everyone.
Very painful as a parent to sit there and have your child ask, what's wrong with me? And I have no answer.
I tried to hang myself, like, a couple years ago, and it really didn't hit me that, like, you know, like, what am I doing? It didn't really hit me until after my parents found out, after my friends found out, and I got sent to inpatient for that.
A friend of mine at work, actually, whose daughter was very ill, was talking to me during lunch about NAMI, which I had no idea about. And I asked her, I said, what is NAMI? And when she explained to me, and she goes, let me give you this number and call.
Good afternoon, NAMI, New Jersey, Sophia Miles. I'll transfer you over to Aruna Rao. One moment, please.
NAMI New Jersey stands for National Alliance on Mental Illness of New Jersey. We are a statewide nonprofit group with a mission of improving the lives of those affected by mental illness and their families. I would say the single common denominator for almost all the families that come in, regardless of race or ethnicity or any kind of background, is the stigma experienced by both families and by individuals who are affected by mental illness.
Each culture expresses it in a different way, so it's not just one size fits all. We have to look at how is it expressed in that culture, what kinds of messages do we need to get and give, and of course what we need is to get that input from people from that culture.
The stigma is shame, embarrassment, which consequently, keeps us from speaking about it in the African American community. We're so used to, keeping everything quiet, and everything has to be hush hush, and we don't want everyone in our business, and we want to keep up with the Joneses.
You're supposed to be Indian. We don't have this kind of issues. What is mental illness? It's just all in your head.
Mi hijo Braulio lleva 4 años, más o menos, con la enfermedad, porque al principio yo no conocía lo que estaba sucediendo. En la comunidad hispana enfrentamos varios problemas, especialmente si uno dice que tiene una enfermedad mental, de una vez le dicen, oh, él está loco.
Maybe it's something you did when you were pregnant. Maybe it's the food you ate. Did you eat pineapple? Pineapple has a way of doing that, it's the acid.
I was diagnosed with bipolar disorder, and during my first manic episode, I was hospitalized for 2 weeks. People have told me, do not talk about it. It will become better if you don't talk about it. It's hard to make them realize that it is a real illness. There's a tendency for them to believe that I could control my behavior and, get better on my own. It's just something I'm not trying.
People think that your parents, they didn't raise you well, or there's a weakness in your character.
They don't take the time to understand. They just want to stick a label on you, and then, they're done with you.
New Jersey's minority population was just huge, and regional and ethnic minorities experience far more barriers to accessing mental health care than the mainstream white population.
We have always wanted to be very inclusive and have all populations, part of NAMI, New Jersey, and benefit from whatever we did. But we found out that it just wasn't happening just by being here and saying, come to us. It wasn't working.
NAMI New Jersey has developed 4 multicultural programs. There is Samhaj, South Asian Mental Health Awareness in Jersey. Then there's CAMHOP, that's Chinese American Mental Health Outreach Program in New Jersey. And then there is NAMI NG en Español, which serves people of Latino origin in New Jersey. Then we have ACT NOW, which is African Americans Take Outreach Worldwide Now, which is targeted at the African American population.
Tonight we're going to go around and ask everyone individually your name and why did you decide to come to the support group?
We've developed support groups that have just started recently, and so far those have been going very well. The buzz is building, and it's just really exciting to see people really now ready to start talking about their experiences and taking responsibility for their health and their life and their family's health.
Clara Morato.
Right now, we have what we call the NAMI en Español program. We do the family-to-family educational program, which is geared towards teaching the families how to deal with mental illness.
I heard about NAMI New Jersey through a friend of mine. He actually runs the In Our Own Voice program, which means that we as speakers go out and speak to various audiences about our recovery. NAMI New Jersey was good enough to have me on as a speaker, so I went out and I pretty much talked to different audiences about my recovery.
I still remember my first day meeting at Samaj. When I walked in, there was 4 other families, couples, parents, who were Indian origin, just like me. And that was like the weight on my shoulder just drained out. I was not alone. I was not the first Indian, and I'm not stigmatized anymore. We can move on. Our family can be helped. My son's going to get the help he needs.
Active patients. You know, you do whatever you can for yourself every day to try to further your cause. But at the same time, let life progress without being anxious about it.
Wake up. Our children have a mental illness just like they have other illness. Address it. Get the help you need. Talk to your children. Leave an open communication. Involve the rest of the family members, especially siblings. Help them. It is not an illness that can take their life over.
Mental illness is treatable and very recoverable. You see before you today someone who is articulate and someone who does not look like she's mentally ill. And I want people to know that if they get treatment and if they get help, they can live a normal life.
Having a mental illness is not a death sentence. There is life after recovery.
Que no se dejen frustrar, que no se dejen caer, que todo pasa y que nada más no son ustedes que tienen este problema, sino somos un grupo muy grande.
My positive journey after I received help was always a constant learning thing. I didn't exactly ever stop recovering. My boyfriend has been with me for 12 years, and he's been wonderful. When he first heard about the diagnosis, he automatically did not characterize me as a person with mental illness. He said, "You're a very brave person to go through this."
It's talking about the recovery process that I went through, narrating my story in different locations to give hope to other people. Once I received help and also learned enough, I did not feel limited by my illness. I was able to be more productive and I was getting more successful in work. I'm able to feel confident that when I wake up in the morning, I'm not going to be insane.
I was thinking, gosh, there's only one voice in my brain and it's mine, you know? And I told my parents about that, and that was like really, really a funny thing for us because, you know, it's been a long road and it's been all of us on it. My family is very, very supportive. My mother and father and my brother. While I was going through all that anguish and turmoil and stuff like that, they were the ones that were the pillars, and they were the ones that had to pay the bills too.
My son has a tattoo on his arm that says, "Let the good times roll." And one of his things is one step at a time and live for the moment.
I love my life. It's great. I want to go to college, Brookdale Community College, major in television production. I bought my own car this year. Like, things could always be better, but you can't ask for that. You gotta just love what you have. Like, life's too short.
The correct answers are A, B, D, and E.
Our brains are amazing. They think about problems, tell body parts to move, tell the stomach how to digest, figure out what we see, taste, smell, and touch. They are the boss of the body. They tell everything else how to work. They even help us feel happy, excited, scared, mad, and sad. Like all body parts, the brain can sometimes have problems working correctly, and this can lead to mental illness. Sometimes brains make people feel worried too much of the time. This is called anxiety. Some brains make people feel too much sadness. This is called depression. Other brains make people feel like they need to repeat actions and that their work is never good enough. This is called OCD. Some brains make people feel very sad at times and overly happy and excited at other times. This is called bipolar. Some brains do not communicate the message to your body that it needs to focus and stay on task. This is called ADD or ADHD. And some brains make people think they hear, see, or touch things that aren't really there, or think things that aren't true. This is called schizophrenia. Why does the brain, the boss of the whole body, not work right sometimes? Doctors and scientists are still learning, but they know it often has to do with how the brain communicates. The brain is similar to a highly organized collection of wires. It receives all the signals that come into the eyes and ears and nose and sends on messages to the mouth and feet and hands. Neurons are like the brain's wires. They are the connectors that move messages along, and there are 100 billion of them at work in the brain all the time. But neurons must talk to other neurons to move messages along, and the way they talk to each other is through chemical messengers. These messengers, called neurotransmitters, cross the tiny gaps in between neurons, ferrying messages from one neuron to the next. When a neuron gets just the right neurotransmitter at just the right time, it helps the brain concentrate, relax, shift attention, and create. But when neurotransmitters aren't able to do their job right, when there are too many messengers or too few, the message is not understood correctly. The brain loses focus, gets tired, worries, or retreats from reality. For example, when neurons called smiley serotonin don't make it across the neuron gap, the brain makes the whole body feel sad and depressed. Doctors have found that if they give a depressed patient some medicine to help smiley serotonin, it helps the brain feel happier. Doctors have discovered many medicines that help correct neurotransmitter levels in the brain. These other medicines influence not only serotonin, but other brain messengers such as do-it dopamine, gregarious GABA, and nerdy norepinephrine. Doctors are also learning that for some brains, eating a healthier diet, exercise, meditation, and enjoying happy relationships can be very helpful in getting neurotransmitter levels back to working order. Our brains work hard being in charge of our bodies. Most of the time, people do not even notice just how well their brains are working. But if pathways in the brain start working poorly, it can be confusing and scary for that person and his family and friends. It is very important that people whose brains need help work closely with their doctor to get the help they need. Doctors know many ways to help get the brain working properly again so that the brain can get back to being a great boss.
A neurotransmitter is a chemical substance that functions as a neuromessenger. There are 4 major groups: monoamines, amino acids, peptides, and cholinergics. Monoamines, like dopamine, norepinephrine, and serotonin, and cholinergics, such as acetylcholine, are implicated in many mental health diseases. Amino acids, such as GABA and glutamate, balance brain activity, and peptides adjust general brain function. After attaching to a receptor and exerting its influence on the postsynaptic cell, the neurotransmitter separates from the receptor and is destroyed. Here are 2 basic mechanisms by which neurotransmitters are destroyed. Some neurotransmitters, such as acetylcholine, are destroyed by specific enzymes at the postsynaptic cell. The enzymes that destroy acetylcholine are acetylcholinesterase. Some neurotransmitters, like norepinephrine, are taken back into the presynaptic cell from which they were originally released by a process called cellular reuptake. Upon their return to these cells, the neurotransmitters are either reused or destroyed by intracellular enzymes. In the case of the monoamine neurotransmitters, norepinephrine, dopamine, and serotonin, the destructive enzyme is called a monoamine oxidase, or MAO. Researchers ultimately want to be able to understand mental dysfunction in terms of altered activity of neurons in specific areas of the brain. The hope is that such an understanding will lead to better treatments and possible prevention of mental disorders. Current interest is focused on certain neurotransmitters and their receptors, particularly in the limbic system, which links the frontal cortex, basal ganglia, and upper brainstem. As mentioned earlier, the neurotransmitters that have been most consistently linked to mental activity are norepinephrine, dopamine, serotonin, GABA, and glutamate. Although the underlying physiology is complex, it is thought that a deficiency of norepinephrine, serotonin, or both may serve as the biological basis of depression, or thought disorders such as schizophrenia are associated physiologically with excess transmission of the neurotransmitter dopamine, among other changes. Dopamine is involved in cognition, motivation, and movement. It controls emotional responses and is the brain's reward and pleasure center. Drugs that interfere with the reuptake allow it to stay in the system longer and balanced by acetylcholine. Cocaine and amphetamines stimulate too much, and haloperidol decreases these functions. Norepinephrine regulates mood and works with serotonin. Excess norepinephrine can cause manic states, and deficiency causes depression. A blockage of these receptors can drop blood pressure and cause ejaculation problems in men. Serotonin, found in the brain and spinal cord, regulates mood arousal, attention, behavior, and body temperature. If antidepressants are combined with other herb or over-the-counter drugs that increase serotonin, it can cause serotonin syndrome. Symptoms of serotonin syndrome include restlessness, shivering, diarrhea, and up to muscle rigidity, fevers, and seizures. One can have serotonin dysfunction, leading to aggression and suicide. Some drugs with highest uptake of serotonin, like Prozac, Paxil, and Zoloft, are associated with altered anticoagulant effects, so the use of NSAIDs, aspirin, and warfarin with them can cause intensified bleeding. Histamine, the H1 receptors, are blocked by many drugs, and the side effect is sedation and weight gain. This can disturb the endocrine system and lead to other medical issues. Gamma-aminobutyric acid, or GABA, regulates neuronal excitability and anxiety. Most anti-anxiety drugs act by increasing the levels of GABA. Glutamate is a very strong excitable neurotransmitter. Too much can lead to overstimulation of cells and cell death, such as with Alzheimer's disease, and also thought to have been overstimulated early in schizoaffective illnesses. Research continues to find a drug to act upon these specific receptors. Acetylcholine is involved in cognition and memory and balances dopamine. This is part of the reward center of the brain. Drugs that enhance secretion of acetylcholine, such as Aricept and Exelon, are used for Alzheimer's disease. The receptors also respond to other molecules, especially nicotine. This is an unconscious form of medicating, especially for those with schizophrenia and ADHD who become easily addicted. Monoamine oxidase inhibitors, or MAOIs, are a group of antidepressant drugs that illustrate the principle that drugs can have a desired and beneficial effect in the brain, while at the same time having possibly dangerous effects elsewhere in the body. To understand the action of these drugs, keep in mind the following definitions. Monoamines are a type of organic compound. It includes the neurotransmitters norepinephrine, epinephrine, dopamine, and serotonin, as well as many different food substances and drugs. Monoamine oxidase, or MAO, is an enzyme that destroys monoamines. Monoamine oxidase inhibitors are drugs that prevent the destruction of monoamines by inhibiting the action of MAO. The monoamine neurotransmitters, as well as any monoamine food substance or drug, are destroyed by the enzyme MAO, which is located in neurons and in the liver. Antidepressant drugs such as Nardil, Parnate, and MSAM are MAOIs. That is, they act by inhibiting the enzyme and interfering with the destruction of the monoamine neurotransmitters. This in turn increases the synaptic level of the neurotransmitters and makes possible the antidepressant effects of these drugs. To better understand this information, refer to your Figure 317 and visit the Evolve website from your book for a more comprehensive explanation of how MAOIs work. The use of monoamine oxidase inhibiting drugs is complicated by the fact that MAO is also present in the liver and is responsible for degrading monoamine substances that enter the body via food or drugs. Of particular importance is the monoamine tyramine, which is present in many food substances such as aged cheeses, pickled or smoked fish, and wine. Tyramine poses a threat of hypertensive crisis because it can produce significant vasoconstriction, thus an elevation in blood pressure, if allowed to circulate freely in the blood. Normally, this does not happen because tyramine is destroyed by MAO as it passes through the liver before entering the general blood circulation. However, in the presence of MAOIs, tyramine is not destroyed by the liver and can cause serious, even life-threatening hypertensive crisis. A substantial number of drugs are chemically monoamines. The dosages of these drugs are determined by the rate at which they are destroyed by MAO in the liver. In a patient taking MAOIs, the blood level of monoamine drugs can reach high levels and cause serious toxicity. Thus, MAOIs are contraindicated with concurrent use of any other antidepressants and sympathetic mimetic drugs. Concurrent use with some of the over-the-counter products with sympathomimetic properties like oral decongestants should be avoided. Tricyclic and heterocyclic antidepressants were widely used prior to the development of SSRIs. Tricyclic antidepressants are no longer considered first-line treatment for depression since they have more side effects, take longer to reach an optimal dose, and are far more lethal in overdose. As the name implies, the selective serotonin reuptake inhibitors, or SSRIs, such as Prozac, Zoloft, Paxil, Celexa, Lexapro, and Luvox, preferentially block the reuptake and thus the destruction of serotonin. SSRIs, as a group, have less ability to block the muscarinic and histamine 1 receptors than do the TCAs. As a result of their more selective action, they seem to show comparable efficacy without eliciting the anticholinergic and sedating effects that limit patient adherence. However, SSRIs have other side effects resulting from stimulation of a variety of serotonin receptors. Stimulation of various serotonin receptors may inhibit the spinal reflexes of orgasm, lead to apathy and low libido, and they may cause nausea and vomiting. Serotonin norepinephrine reuptake inhibitors, or SNRIs, are medications that increase both serotonin and norepinephrine. Effexor is more of a serotogenic agent at lower therapeutic doses, but norepinephrine reuptake blockade occurs at higher doses, leading to the dual SNRI action. Hypertension, induced in about 5% of patients, is a dose-dependent effect based on norepinephrine reuptake blockade. Doses higher than 150 milligrams a day can increase diastolic blood pressure about 7 to 10 millimeters of mercury. Cymbalta is an SNRI indicated for both depression and diabetic peripheral neuropathy. Like the tricyclic antidepressants, many of the SNRIs also have therapeutic effects on neuropathic pain. The common underlying mechanism of neuropathic pain is nerve injury or dysfunction. The mechanism by which TCAs and SNRIs reduce neuropathic pain is through activation of the descending norepinephrine and serotonin pathways to the spinal cord, thereby limiting pain signals ascending to the brain. The symptoms, neurotransmitters, and circuits associated with anxiety disorders overlap extensively with those of depressive disorders, and many antidepressants have proven to be effective treatments for anxiety disorders. Selective serotonin reuptake inhibitors, or SSRIs, are often used to treat OCD, social anxiety disorder, generalized anxiety disorder, panic disorder, and post-traumatic stress disorder. Effexor XR is used often to treat these disorders. Cymbalta has recently been FDA approved for generalized anxiety disorder. The class of drugs described as serotonin norepinephrine disinhibitors, or SNDIs, is represented by only one drug, mirtazapine or Remeron, which increases norepinephrine and serotonin transmission by blocking presynaptic alpha-2 noradrenergic receptors. Mirtazapine offers both anti-anxiety and antidepressant effects with minimal sexual dysfunction secondary to serotonin blockade. This antidepressant is particularly suited for the patient with nausea because it is an antiemetic via serotonin blockade, and the most common side effects are sedation and weight gain. Wellbutrin is an effective antidepressant and is also used for smoking cessation by the name Zyban. It seems to act as a dopamine norepinephrine reuptake inhibitor and also inhibits nicotinic acetylcholine receptors to reduce the addictive action of nicotine. Since buprone has no serotonin action, it does not cause sexual side effects. Side effects do, however, include insomnia, tremors, anorexia, and weight loss. Wellbutrin is contraindicated in patients with seizure disorder, patients with a current or prior diagnosis of bulimia or anorexia, and in patients undergoing abrupt discontinuation of alcohol or sedatives. This includes benzodiazepines owing to the additive seizure risk. Trazodone is not a first choice for antidepressant treatment, but it is often given along with other agents because of sedation properties, one of the most common side effects, which helps fight insomnia. Its antidepressant effects are only seen at high therapeutic doses. The common side effects are sedation and orthostasis. Trazodone's sedative effect is from both potent, like the histamine 1 blockade. Orthostasis is from alpha-1 adrenergic blockade. One rare side effect from alpha-1 adrenergic blockade is priapism. There are 5 benzodiazepines approved by the U.S. Food and Drug Administration, or FDA, for the treatment of insomnia. There's flurazepam, temazepam, triazolam, estazolam, and quazepam, with a predominantly hypnotic effect. Other benzos, such as lorazepam and alprazolam, reduce anxiety without inducing sleep at low therapeutic doses. The fact that the benzodiazepines potentiate the ability of GABA to inhibit neurons probably accounts for the effectiveness as anticonvulsants and for their ability to reduce neuronal overexcitement of alcohol withdrawal. When used alone, even at high doses, these drugs rarely inhibit the brain to the degree that respiratory depression, coma, and death result. However, when combined with other central nervous system depressants, such as alcohol, opiates, or tricyclic antidepressants, The inhibitory actions of the benzos can lead to life-threatening CNS depression. Buspirone, or Buspar, is a drug that reduces anxiety without having strong sedative hypnotic properties. Because this agent does not leave the patient sleepy or sluggish, it is often better tolerated than benzos. It is not a CNS depressant and thus does not have a great danger of interaction with other CNS depressants, such as alcohol. Also, there is not the potential for addiction that exists with benzos. Its mechanism of action is unknown, but it has a high affinity for serotonin receptors, acting as a serotonin 1-alpha partial agonist. The most common side effects for Buspar include headache, dizziness, lightheadedness, nausea, and insomnia. A newer class of hypnotics, termed the Z-hypnotics, due to their sleep-inducing properties, include Ambien, Sonata, and Lunesta. They have sedative effects without the anti-anxiety, anticonvulsant, or muscle relaxant effects of benzos, and they demonstrate selectivity for GABA-A receptors containing alpha-1 subunits. The drug's affinity to alpha-1 subunits has the potential for amnesia and ataxic side effects, and on the onset of action is faster than that of the potential for most benzos. It is important to inform patients taking non-benzodiazepine hypnotic agents about the quick onset and advise them to take the drug when they are ready to go to sleep. Most of these drugs have short half-lives, which determine the duration of action. Lunesta has the longest duration of action, which is about an average of 7 to 8 hours of sleep per therapeutic dose. The short half-life of Ambien and Sonata are significantly shorter than Lunesta. The Lunesta also has the unique side effect of an unpleasant taste upon wakening. Although tolerance and dependence are reportedly less than that with benzos, all of the benzodiazepines and Z-hypnotics are categorized as Schedule C 4 by the Drug Administration, or the DEA. Melatonin is a hormone that is only excreted at night as part of the normal circadian rhythm. Resirem, the latest FDA-approved hypnotic drug, is a melatonin receptor agonist and acts much the same way as naturally occurring melatonin. It has a high selectivity and potency at the melatonin 1 receptor site. The area that is thought to regulate sleepiness, and at the melatonin 2 receptor site, where it is thought that the circadian rhythm is regulated. This is the only hypnotic medication approved for the treatment of insomnia that is not classified as a scheduled substance or one having abuse potential by the DEA. Side effects include headache and dizziness. Although most of the hypnotics are indicated for short-term use, the two newest hypnotics on the U.S. market, Lunesta and the Resirem, are not restricted to short-term use on the package labeling. Long-term use of the Resirem above therapeutic doses can lead to increased prolactin and associated with side effects such as sexual dysfunction, though. Although the usefulness of lithium, also known as Escalith or Lithobid, as a mood stabilizer in patients with bipolar manic depressive disorder has been established for many years, its mechanism of action is still far from understood, though. As a positively charged ion, similar in structure to sodium and potassium, lithium is thought to act by affecting electrical conductivity in neurons. The fact that sodium and potassium play a strong role in regulating fluid balance and the distribution of fluid in various body compartments explains the disturbances in fluid balance that can be caused by lithium. These include polyuria and edema. Long-term use of lithium can cause hypothyroidism in some patients by interfering with iodine molecules and affecting formation of and conversion to the active form of thyroid hormone, the triiodothyronine, or T3. In addition, hyponatremia can increase the risk of lithium toxicity because increased renal reabsorption of sodium leads to increased reabsorption of lithium as well. Primarily because of its effects on electrical conductivity, lithium has a low therapeutic index. The therapeutic index represents the ratio of the lethal dose to the effective dose and is a measure of overall drug safety in regards to the possibility of overdose or toxicity. A low therapeutic index means that the blood level of a drug that can cause death is not far above the blood level required for drug effectiveness. This mandates that the blood level of lithium be monitored on a regular basis to be sure that the drug is not accumulating and rising to dangerous levels. Valproate has several different forms. It is available as divalproic sodium or Depakote and valproic acid or Depakine. Carbazepine or Tegretol and lamotrigine or Lamictal have demonstrated effectiveness in the treatment of bipolar disorders. Their anticonvulsant properties derive from the alteration of electrical conductivity in membranes. In particular, they reduce the firing rate of very high-frequency neurons in the brain. It is possible that this membrane-stabilizing effect accounts for the ability of these drugs to reduce the mood swings that occur in patients with bipolar disorders. Other proposed mechanisms as mood stabilizers are glutamate antagonists and GABA agonists. Valproate is structurally different from other anticonvulsants and psychiatric drugs that show effectiveness in the treatment of bipolar. Divalproix is recommended for mixed episodes and has been found useful for rapid cycling. Common side effects include tremor, weight gain, and sedation. Occasional serious side effects such as thrombocytopenia, pancreatitis, hepatic failure, and birth defects also occur. Baseline levels are measured for the liver function indicators and complete blood count before an individual is started on this medication, and measurements are repeated periodically. In addition, the therapeutic blood level of this drug is monitored routinely. Carbazepine or Tegretol is useful in preventing mania and used during episodes of acute mania. It reduces the firing rate of overexcited neurons by reducing the activity of sodium channels. Common side effects include anticholinergic side effects such as dry mouth, constipation, urinary retention, blurred vision, orthostasis, sedation, and ataxia. Recommended baseline laboratory work includes liver function tests, CBC, electrocardiogram, and electrolyte levels. Blood levels are monitored to avoid toxicity, which is anything more than 12 micrograms per milliliter, but there are no established therapeutic blood levels for carbazepine in the treatment of bipolar disorder. Lamictal is approved by the FDA for maintenance therapy of bipolar disorder, but is not effective in acute mania. Lamictal works well in treating the depression of bipolar disorder with less incidence of switching the patient into mania than other antidepressants would. It modulates the release of glutamate and aspartate. Patients should promptly report any rashes, which could be a sign of Stevens-Johnson syndrome. This is a life-threatening disease. This can be minimized by slow titration of the therapeutic doses, though. Other anticonvulsants used as mood stabilizers are Neurontin or gabapentin, Topamax, and oxycarbazepine. None of these have FDA approval as mood stabilizers, though, and studies have not provided strong support for their use as a primary treatment for bipolar. Antipsychotic medications and anti-anxiety medications such as clonazepam are used for their calming effects during mania. First-generation antipsychotic drugs, or conventional antipsychotics, are strong antagonists at the D2 or dopamine receptors. By binding to these receptors and blocking the attachment of dopamine, they reduce dopaminergic transmission. It has been proposed that an overactivity of the dopamine system in certain areas of the mesolimbic system may be responsible for at least some of the symptoms of schizophrenia. Thus, blockage of dopamine may reduce these symptoms. This is thought to be particularly true of the positive symptoms of schizophrenia, such as delusions and hallucinations. Because dopamine in the basal ganglia plays a major role in the regulation of movement, it is not surprising that dopamine blockage can lead to motor abnormalities, such as Parkinsonism, akinesia, akathisia, dyskinesia, and tardive dyskinesia. Nurses and physicians often monitor patients for evidence of involuntary movements after the administration of these conventional antipsychotic agents. Many of these conventional antipsychotics, as well as a variety of other psychiatric drugs, block the H1 receptors for histamine. The two most significant side effects of blocking these receptors are sedation and substantial weight gain. The sedation may be beneficial in severely agitated patients, though. Non-adherence to the medication regimen is a significant issue because of these troublesome side effects, and the atypical antipsychotics have consequently become the drugs of choice. The second generation of antipsychotic drugs includes the atypical antipsychotics, which produce fewer extrapyramidal side effects, also known as EPS. They target both the negative and positive symptoms of schizophrenia. These newer agents are often chosen as first-line treatment over the conventional antipsychotics because of their lower risk for EPS. However, 5 of the 7 available atypical antipsychotics can increase the risk for metabolic syndrome, with increased weight, blood glucose, and triglycerides. The simultaneous blockade of the 5-HT2C and H1 receptors is associated with weight gain due to increased appetite stimulation via the hypothalamic eating centers of the brain. Strong antimuscarinic properties at the M3 receptor on the pancreatic beta cells can cause insulin resistance, leading to hyperglycemia. The receptor responsible for elevated triglycerides is currently unknown. Clozapine and olanzapine have the highest risk of causing metabolic syndrome. Abilify and Geodon have the lowest. The atypical antipsychotics are predominantly dopamine and serotonin antagonists. The blockade at the mesolimbic dopamine pathway is thought to decrease psychosis, similar to the mechanism by which the conventional antipsychotics work. Decreasing dopamine can reduce psychosis, but can also have adverse side effects elsewhere, such as the movement side effects of EPS, the worsening of cognitive and negative symptoms, and an increase in the hormone prolactin. This can lead to the gynomastia and galactorrhea, amenorrhea, or low libido. Clozapine is the first of the atypicals. It is an antipsychotic drug that is relatively free of motor side effects of the phenothiazines and other atypical antipsychotics. It is thought that clozapine preferentially blocks the dopamine receptors in the mesolimbic system rather than those in the neurotriastal area. This allows it to exert its antipsychotic action without leading to difficulties with EPS. Although people who take clozapine are more likely to adhere to their medication regimen than those who are taking other atypical antipsychotics, it can lead to a potentially fatal side effect in up to 0.8% of the patients. Clozapine has the potential to suppress bone marrow, induce the granulocytosis, but because of the deficiency in the white blood cells, it renders a person prone to serious infection. Regular measurement of white blood cell count is required on this medication. Typically, the count is measured weekly for the first 6 months, every other week for the next 6 months, and then monthly thereafter. However, newer research indicates that it is medically justifiable to discontinue the blood counts after 6 months if a knowledgeable patient does not want them, especially if adherence is jeopardized. Clozapine has the potential for inducing convulsions. It's just a dose-related side effect in 3.5% of patients. Caution should be used, though, with other drugs that can increase the concentration of clozapine. There is also a potential for myocarditis that should be monitored, but the most common side effect of clozapine are drowsiness and sedation. Hypersalivation, weight gain, reflex tachycardia, constipation, and dizziness are also seen. Risperidone, or Risperdal, has a very low potential for inducing a granulocytosis or convulsions. However, high therapeutic doses, which is greater than 6 milligrams a day, may lead to more motor difficulties. It has the highest risk of EPS among the atypical antipsychotics and may increase prolactin, which may also lead to sexual dysfunction. Risperdal can also cause orthostatic hypotension, which can lead to falls, which are a serious problem among older adults. Weight gain, sedation, and sexual dysfunction are adverse effects that may affect adherence with the medication regimen and should be discussed with patients. It is notable that Risperdal is the first atypical antipsychotic available as a long-acting injection. Risperdal Consta, administered every 2 weeks, provides an alternative to the conventional form of the antipsychotics. A rare but serious side effect is an increased risk for cerebrovascular accidents or stroke in older adults with dementia who are being treated for agitation. The quetiapine or Seroquel has a broad receptor binding profile. It is a strong blockage of H1 receptors accounts for the high sedation. The combinations of H1 and serotonin receptor blockage leads to the weight gain associated with this drug and also to a moderate risk for metabolic syndrome. It causes moderate blockage of alpha-1 adrenergic receptors and associated orthostasis. Seroquel has a low risk for EPS or prolactin elevation from low D2 dopamine binding due to a rapid dissociation at these receptors. Other atypical antipsychotics include Zyprexa, Geodon, Abilify, and Invega. Zyprexa is similar to clozapine in chemical structure. Side effects include sedation, weight gain, hyperglycemia, with new onset type 2 diabetes, and higher risk for metabolic syndrome. Geodon is a serotonin norepinephrine reuptake inhibitor. The main side effects are dizziness and moderate sedation. Geodon is contraindicated in patients with a known history of QT interval prolongation, recent acute myocardial infarction, or uncompensated heart failure. Abilify is a unique atypical antipsychotic known as a dopamine system stabilizer. In areas of the brain with excess dopamine, it lowers the dopamine level by acting as a receptor antagonist. However, in regions with low dopamine, it stimulates receptors to raise the dopamine level. It has little sedation and weight gain side effect, but some side effects that are included are insomnia and the akathisia. Invega, the newest antipsychotic in the United States, is the major active metabolite of risperidone. It has similar side effects such as EPS and prolactin elevation. Its side effects are orthostasis and sedation. The osmotic release oral system, or OROS, provides consistent 24-hour release of this medication, leading to minimal peaks and troughs in plasma concentrations.